Boa noite a todos, bem-vindos ao Clube da Artéria. Hoje nós temos um convidado muito querido a todos nós, Dr. Peter Gloviczki, que está nesse momento em Rochester, Minnesota, e muito gentilmente aceitou o convite para participar do nosso evento. Gostaria de pedir a todos que mantivessem os seus microfones desligados. Ao fim da apresentação, nós teremos tempo para debate. Quem quiser fazer perguntas para o Dr. Peter, pode levantar a mão marcando aquele ícone do sistema ou mandar mensagens de texto. Lembrando a todos que as apresentações são gravadas no nosso canal do YouTube e quem quiser, enfim, obter mais informações do Clube da Artéria, enviar e-mail para pós-graduação @centervasc.com.br. Chamo agora o Dr. Arno para as palavras iniciais.
Boa noite. Eu gostaria de dar boas-vindas a todos a mais uma edição do Clube da Artéria e dar as boas-vindas, sobretudo, a Peter Gloviczki, que, além de ser uma pessoa que eu tenho uma relação de amizade pessoal, mas o Peter, ele é um dos responsáveis pela grande aproximação da comunidade cirúrgica vascular americana com o Brasil, foi um dos idealizadores do capítulo brasileiro da Society for Vascular Surgery e, eu diria, um grande amigo do nosso país. E ele gentilmente aceitou fazer essa apresentação sobre um tema que, sem dúvida, é uma das maiores experiências mundiais, que é em reconstruções venosas. Peter, I'm saying welcome to you, and most of the people who are online know already your importance to Brazil, because I've just said that you're a friend of Brazil. You have been here several times, and you were one of the mentors of the Brazilian chapter of the SVS, which you have been president and now editor-chief of the Journal of Vascular Surgery. So, Peter, be very welcome, and we're very happy to be with you. Okay, I think we can start, Bernardo.
Well, thank you very much, Arno, and thank you very much, everybody. Good evening. I am indeed a great friend of so many of you. Obviously, I visited your country so many times, and with Gustavo Oderich and Bernardo Bernardo Mendes, being my colleagues here, I certainly had a lot of exposure to Brazilian medicine, surgery, and other things as well, including a lot of friendship with Professor Arno von Ristow and his wonderful wife, Anna. And we were also obviously very happy to have Bernardo Massière spending time with us. I noticed this is an arterial club, Arno, but I'm going to talk about venous surgery that is so close to my heart, that has not only South American roots, but also is a challenging part of vascular surgery. So I'm going to share my slides. And can you see my slide?
Yes, we do.
That's wonderful. So I'm going to talk about an art that I hope is not a lost art. It is the art of open venous surgery, open venous reconstruction, in our times when obviously we do endovascular procedures most of the time. You obviously know that acute venous thromboembolism is extremely frequent in the United States. It's it affects about 1 patient per 1,000 patient years. almost 1 million Americans have thromboembolism in 1 year. Death is at least 100,000 a year, if not 200,000 to 300,000. We are not really sure about that. Many patients with venous thromboembolism have recurrence, and what is important for us vascular surgeons is post-thrombotic syndrome and post-thrombotic disease that can affect up to half of the patients who have acute deep vein thrombosis. Now, chronic venous disease is a spectrum of problems. It starts with varicose veins, and then it goes to skin changes, healed and active ulcerations. And in the United States, it's a major issue. 25 to 40 million Americans have varicose veins or more advanced venous insufficiency. At least 2 to 4 million have what we call C5, C6, C4 disease, and up to 1 million have venous ulcers. Now, the endovascular revolution changed everything in our profession. It certainly changed tremendously aortic disease and arterial vascular interventions, but it also changed vein care forever. And in the last 2 decades, we do superficial venous interventions percutaneously, with endovenous technique in the office using these different type of modalities. And that's not what I would like to talk about. I would like to talk about more on deep venous disease, but also deep venous disease, acute or chronic, are treated with endovenous interventions, thrombolysis, thrombectomy, angioplasty, and stents. Certainly, iliofemoral venous stents revolutionized the way we treat patients with deep venous obstruction at the pelvic level. They have worked out very well for post-thrombotic patients, and especially so for patients who have non-thrombotic iliac vein compression, like May-Turner syndrome. In the United States, the first 15 years experience actually came from wall stent. That was really the only stent that we had available. And in the seminal study of Neglen and Raju, where they reported long-term results in 982 patients, they found that secondary patency of post-thrombotic patients was 86% at 5 years. And practically an amazing result of 100% secondary patency of non-thrombotic patients who had symptoms and due to iliac vein compression. In the United States, and I presume in Brazil, you have more dedicated venous stents. In the United States, last year, 2 new stents were approved, and the studies are coming out, although no comparative studies are available, but the initial results are very good, and clearly placement of these stent is easier and more precise than with the wall stents. So even in extremely extensive acute on chronic or chronic occlusions, here at Mayo Clinic too, we would do everything to recanalize extensive iliocaval obstruction with complex stenting, iliac and inferior vena cava stenting. And this is just one of the papers where we reported in 66 patients who had complex caval stenting going all the way up to the hepatic vein with an 82% 5-year patency. So what about the open surgery and hybrid procedures in some cases? Obviously, these are now done in patients who are either not candidate or who fail endovenous procedures. And you would think that the list is quite short today for open venous surgery, but indeed, it is a pretty good and long list for aneurysms, for obstructions, and for valve incompetence. And in the interest of time, I'm just going to focus to a few areas, and then we can talk about some specific other examples later. And let's start with venous aneurysms, because if you do any type of venous surgery, sooner or later, you see patients maybe just with a very ordinary, large, localized varicose vein, which actually sometimes is clearly a saphenous vein or superficial vein aneurysm that's very frequently right at the saphenofemoral junction levels. The fact is that practically all superficial venous aneurysms can be excised with simple surgery and usually is not a complex problem. It is more complex when you have a popliteal vein aneurysm. And the popliteal vein aneurysm can be located, and most frequently, I would say, it's located in the mid portion, but it can also be like, in this specific case, just distal to Hunter's canal. It is actually a compression related aneurysm in this relatively young male patient who actually had this aneurysm discovered after a pulmonary embolism. This shows the aneurysm that we operated on through a distal thigh incisions, and after freeing up the Hunter's canal and opening up the adductor tendon that was clearly compressing the vein in this area, we found actually this large sac of the aneurysm obviously did the intra-duplex that showed no fresh thrombus in the aneurysm, so it was a relatively easy excision of the aneurysm. One technique that I have done in a couple of patients with these aneurysms to be sure that you have a very safe and good lumen, we actually placed a balloon catheter into this patient here with an 8mm balloon, and then put a small clamp on the vein and excised the aneurysm and just oversewed it with in 2 layers with running 6-0 polyene sutures, and it shows the outcome. And this patient has now many years follow-up and has been doing very well. Occasionally, I'm sure that you see it in Rio as well, either as a gunshot injury or as an iatrogenic injury. This patient had an arteriovenous aneurysm. The aneurysm was in the popliteal vein, and it was a bilobed aneurysm. It was a 22-year-old male who had this pulsatile mass. Actually, he had arthroscopic surgery. He was playing as a football player and came on crutches because it couldn't really extend. By the time he got to us, couldn't really walk normally. And after imaging studies and duplex evaluation, we decided for open surgery. And you can see that there was a very large tear and a quite a big defect between the venous aneurysm and the artery that ultimately we reconstructed with 2 saphenous vein interposition grafts, one for the artery, the other one from the vein that we took from the other side. And we had excellent clinical result. Occasionally, you see venous aneurysms in the abdomen. Portal vein aneurysm is just one of the aneurysms that can be symptomatic. Obviously, we watch these quite a bit because any type of reconstructive surgery of this is quite complex. They can thrombose, or occasionally they can rupture. Occasionally they can even regress. But this patient was symptomatic, had pain for several years. This shows the exposed portal vein aneurysm, superior mesenteric vein, inferior mesenteric vein, splenic vein, portal vein. You see the pancreas here on vessel loops that you don't frequently see. And we actually, again, there was no thrombus in it, so we could just place clamps on the vein and in the endoaneurysmal raphe and narrowed the vein down. And this patient did very well, actually, several years after the operation. It somehow even got to the front page of the Journal of Vascular Surgery. And I wasn't the editor at that time, Arno, but it made it. We see congenital aneurysmal veins occasionally. This was a case that we reported. This was quite an amazing example of persistent lateral embryonic vein in a patient with Klippel-Trenaunay syndrome. You can see the patient was very symptomatic, couldn't really function without compression stockings. You see the lateral embryonic vein that was actually, in his case, the size of his inferior vena cava. And in this case, we decided that open surgery is the best. You can see that these patients have huge perforating veins that you really want to control with ligature, localize it with intraoperative mapping, and then excise the veins through multiple smaller incision. This shows the end result. Needed some additional sclerotherapy sessions, but he had a very good functional and even cosmetic, but mostly functional result. Most of the time, obviously, patients who have venous obstruction, that's when we would do some kind of a venous reconstruction for post-thrombotic obstruction, or occasionally for some kind of venous compression syndrome, or patients who have a tumor that invades usually the inferior vena cava or other pathologies. This is a patient who had symptomatic deep venous disease, long-standing deep venous obstruction. He was actually a long-distance runner. And I sent him back multiple years. I told him we are not going to deal with him because he says life is not good because he has to stop after 2 miles. He cannot run longer. I said 2 miles is it's kind of a pretty good claudication. But anyhow, ultimately, when we studied him in detail, it turned out that he has a femoropopliteal deep venous obstruction. This is a profunda system. And actually, he had a well-preserved saphenous vein. So we see it quite frequently that patients who have deep vein thrombosis have actually a preserved and even competent superficial system. But anyhow, obviously, this drainage was not enough for him when he exercised. So we did what we call the May-Husny procedure, which is a saphenous vein turned down. I think originally most of the patients that May and Husni did were below the popliteal transpositions. In this patient, we had a pretty good stump of the popliteal vein, and we just did a turn down of the saphenous vein using a tourniquet. And we could do it practically without placing any clamp, obviously, on the saphenous vein or on the deep system that frequently is a post-thrombotic vein that could be easily damaged with clamping. And this patient did very well. You can see this is the, I believe, 6 month or a year postoperative CT venogram that we get. Had an excellent saphenous vein, excellent patency. Somehow this made it to the front page of the Journal of Vascular Surgery as well. But the interesting clinical follow-up was that after 2 years, he came back and he was running ultra marathons. And so I asked him, how did it go? And he says, well, you know, after 60 miles, I had to stop. I said, you had to stop? Oh, that's too bad. He said, yeah, I had hives. I said, not because of the leg. So actually, this worked out pretty well for him. I can see that in a good patient, if you have a good anatomy and a good technique, it can work. This is just a small series for the University of Michigan that actually showed a 70% patency of these transpositions. You all know very well, you know, Palma and Esperon in Montevideo taught us how to do these crossover bypass procedures. It has a learning curve in my experience, but if you have a good vein, if you have a good inflow, this is actually an excellent operation. You see the obviously widely patent contralateral iliac vein. This patient actually had a right-sided occlusion, so we took the vein from the left side and pulled it over. This was, as you could see, a pretty good size vein, about 6 to 7 millimeter in size. And this shows the patent bypass. This patient, actually it was Dr. Raju who sent me this patient. This patient had a pelvic tumor, and obviously they ligated or injured the veins, and endovascular procedure was not possible. In a patient like that, or in any patient, we would obviously try an venous procedures, but obviously this patient was not, and this patient had excellent clinical outcome. And these are just a few of the palmographs that we have done in the past. Today, we really almost only do it for patients who failed endovascular procedures. This was one of the study where we reported results of 60 procedures, 60 venous reconstruction, 25 patients had a Palma procedure, 78% 5-year patency and 65% patency later on. Not as good as arterial procedures, but these patients are frequently desperate. This was an interesting case that we also published because it shows that with time, these veins actually will or can enlarge. This was a patient who came back 22 years after I did a cross-femoral graft, and you can see that the size of the, this was a control venogram. We fixed a small aneurysmal dilation here, but it's really, this patient had an excellent clinical result from the dilated veins. If vein is not available, I used to try cross-femoral PTFE with an AV fistula. Now I would much more do an inline femorocaval bypass. This is a patient who had bilateral failed stent, mostly left-sided symptoms. This is a PTFE graft with a loop arteriovenous fistula. We use these loops, PTFE grafts, because 4 to 6 weeks later, we come from the other side and do a percutaneous Amplatz closure of the fistula. This shows a postoperative result in a CT venogram. This is another patient with a good inflow iliocaval PTFE graft with an arteriovenous fistula here. These are a couple of PTFE grafts that have worked for very long. On the one on the left side, well, actually even beyond 13 years. So if you have a good inflow, these patients are usually anticoagulated because it's still a thrombogenic graft. Occasionally we did bifurcated graft reconstructions. We do it in a desperate situation, usually try to be on one side. If the inflow is poor, and it was one of the initial series that we reported, we do an endophlebectomy of the femoral vein to improve the inflow and then stent it from there. This shows the stent that goes up. We close the endophlebectomy site with a patch, and this shows the reconstruction here. This is the result. The best results of these venous bypasses are from short graft, obviously the palmograft, and the longer femorocaval or bifemorocaval, or even the crossover femorofemoral PTFEs don't do very well. We had a great interest in tumor surgery, and I'm sure that many of you see patients or work together with general surgeons when you do large vein reconstruction. Tom Bauer has written several articles about resection of primary and secondary tumors of the vena cava. The results usually are determined by the underlying malignancy, because the inflow is usually very good, and we usually don't do an AV fistula in these patients, and the patency is well above 90%. This shows a large leiomyosarcoma that I operated, and this shows the reconstruction. We could even actually save the kidney in this patient. This is just an interesting case. I show it to you because it had a very rapid progression within a few months. This patient had first an infra or pararenal tumor, and then very soon, within a few months actually, this tumor filled the right atrium here, and this was the tumor portion of the thrombus with a thrombus extension more distally. And we did this resection with the cardiac surgeon. This just shows our minimally invasive incision here, right from the jugular going down to the mid-abdomen. Did this patient with cardiopulmonary bypass and mobilized the liver, and we were able to actually, this is the tumor in the right atrium. This shows the liver was mobilized to the right. This shows the incision, and we found that the tumor was, it was a synovial sarcoma, interesting, not a leiomyosarcoma. And this originated from the posterior wall of the vena cava that we could excise, and then actually we had enough native wall that we could just do a patch and reconstruct the cava. I'd like to say a few words about complications of endovascular treatment, because we are seeing more patients, and I'm sure you see more patients too, not only iliac vein, iliac stent thrombosis that may need a Palmer procedure, but other issues. This is a patient, for instance, that we reported who had a huge, it was a relatively small lady and had two 20 millimeter iliac wall stent placed. And the patient, from the minute of the procedure until about 2.5 years later, when she got to me, she had tremendous pain that really destroyed her quality of life. And she was going around trying to persuade surgeons to remove this stent. And this shows you the stent. It had a little bit of a perforation of the vena cava on the other side too, but it was really a large stent, and it was simply just the sheer size that caused. We didn't find any nerve compression. So the procedure was, we were ready to do a large venous reconstruction, but this just shows you the procedure we did. This was a wall stent. We just started out with a midline mini laparotomy. It was a young woman, and just exposing the anterior wall of the stented vein. And this stent was placed 2.5 years ago, so there was actually quite a bit of pseudointima. So the way we proceeded, we used a vein hook and loosened up one of the wires of the stent. And wall stent is actually made of individual wires. So once you remove a stent and you go in the middle, then you can actually pull one way and the other. And once you remove 2 or 3 of these wires, they actually come up pretty easily. So ultimately, we did not have to do a venous reconstruction. We could, with a vein hook, remove the entire stent from the iliac vein. And this shows you after removal of the first stent, and then this shows the after removal of the second stent. You can only do it with the wall stent because the wall stent has these individual wires. Now, we thought that we were done, but unfortunately, when we got a duplex scan, we found that there was a very thick pseudointima that, because the stent completely covered the contralateral side, actually this pseudointima completely occluded the inflow from the contralateral iliac vein. So we didn't have to do any type of venous reconstruction, but we opened up the cava, and you can see this is what we found, that the vein, the flow was through the stent, and you can see the orifices of the stent, but actually already half of the inflow was thrombosed, and this membrane completely occluded the inflow, and then we excised this whole membrane. This is in 2 pieces. So what this tells me and told us that indeed with time, these stents, if you place it across the contralateral iliac vein, you have a high chance that this type of pseudointima forms there, and your patient ultimately will have a thrombosis. This just shows the final reconstruction. And interesting enough, there was a paper that was published just in 2018 that looked at different level of coverage of the contralateral iliac vein by the wall stent. And you see that once the stents reached the contralateral iliac vein, then the contralateral DVT incidence suddenly became significant. So when you stent it, be sure you don't cover it completely. Frequently, you have to cover it a centimeter or so, but my recommendation is that you be careful and don't cover the contralateral side, because your patient may finish up with a thrombosis. Just a couple of cases on nutcracker syndrome, because I've seen so many endovascular procedures that did not succeed with this type of pathology. And I think that we currently don't have dedicated stents for renal vein. And you just see some of the complications that many of them were not reported. You know, came to the Mayo Clinic because they were treated elsewhere. Stent fractures, residual stenosis, stent migration. It either migrates into the kidney hilum or it migrates into the IVC and the right heart, occasionally even needing median sternotomy. Actually, Gustavo had one patient where actually it slipped out. They noticed it and they could remove it. Fortunately, the stent was didn't migrate from the vena cava. This is a completely misplaced stent that actually slipped out. You can see it perforated the renal vein and then completely occluded the inferior vena cava, and it needed open repair to remove the stent. So currently, this is what we do for nutcracker syndrome. We expose it through a relatively small 8 to 10 centimeter long incisions. Many of these people are young, thin teenagers, and we just place a clamp and then we pull the vein down and resuture it. Usually I take, as you could see, a little portion of the inferior vena cava wall to make it actually longer, and this is the open transposition that we do. If there is a stretch or the vein doesn't seem large enough, then we either add a cuff or do a patch on the renal vein. And then finally, I just want to touch very briefly superior vena cava syndrome, because open venous surgery here is extremely rewarding. And these patients, many of them went through endovascular procedures numerous times, are actually really very thankful and have a spectacular result. Patients, obviously, the primary procedure we do is stenting, balloon angioplasty first, and then stenting. Frequently, if it is for benign pathology, particularly for mediastinal fibrosis, we have to come back multiple times, re-balloon it, re-stent it. But many of these patients are okay coming back every second year for additional treatment, but some of them are not, or some of them have more extensive disease. So again, the primary treatment is endovascular, but if the occlusion is very extensive and chronic, like in this patient, then we would do some kind of a open reconstruction. And if it's a relatively short graft, like it's the left innominate vein and the lowest portion of the superior vena cava, we use a 12 or 14 millimeter ringed Gore-Tex. That's a very appropriate and good operation. This shows the postoperative result in this patient. If we have to come out to the neck, certainly very rarely, just in case there is no autologous material, would use a PTFE graft. This shows some of the grafts that we have used. We have a quite large experience with spiral vein, femoral vein graft, but many of these patients have underlying thrombophilia. So some of them are young, many are young, and deep vein thrombosis or symptomatic swelling is an option, and PTFE graft if they don't have others. Just show you a small video of how I do a spiral vein graft, because you may need it for, you know, other femoral vein or iliac vein reconstruction. You can see that we remove the vein that's frequently in spasm or sometimes just not big enough, but then we have to spend more time to do a spiral graft from it. I like to excise the valves from the graft just because they may interfere with the blood flow. I usually use a 28 or more frequently a 32 chest tube, archive chest tube. And we do it with a second team on the side table during the time we do the exposure and irrigate it very abundantly. Usually do a stay suture every 360 degrees just to minimize even any chance of purse stringing. You can use two saphenous vein, actually two proximal saphenous vein pieces that we put together here that gave us a 15 centimeter long graft. So it can take easily an hour, 15 minutes to make the graft, but it's worthwhile. This shows a spiral vein graft in an innominate atrial appendage position. We have had a very good experience. If the patient has severe mediastinal fibrosis, then actually we try to use an externally supported PTFE graft, but you can see a spiral vein graft, femoral vein graft, and PTFE. This was another patient that actually we just did through two very small incision, did an innominate vein reconstruction with a femoral vein, a partial sternotomy, and a high neck incision. And this shows the reconstructed internal jugular and right innominate vein. So we published results of 44 patients. Usually the results are very good in the long run, although sometimes secondary endovascular interventions are needed. So to sum it up, open surgical reconstruction of large vein is an effective and durable procedure. It is an excellent option for patients who are unsuitable for or fail endovascular repair. Just a thought that there are so many specialties today, at least in the United States, who compete for patients with venous disease. Mostly these are specialties who want to do the treatment of superficial veins. On the other hand, open venous surgery is really belongs to vascular surgeons or cardiac or cardiovascular surgeons if it is in the chest. So my advice to you is that, number one, open venous reconstructions are important in the endovascular era. So learn them, do them, and teach them so people know how to do it. And I finish up with this picture of one of my patients who had superior vena cava reconstruction. You can see her scars up here. I did it now for over 10 years, and she's finishing the San Francisco Marathon. Thank you very much. Please read and contribute to the Journal of Vascular Surgery. Thank you. I'm open for any questions you may have.
Dr. Gloviczki, thank you very much. It was a spectacular presentation. It's an interesting, very interesting subject and really amazing cases. Thank you very much for sharing with us this experience. I have plenty of questions, but I would like to ask you some now. There is you just spoken complications regarding the endovascular treatment of the May-Turner syndrome. In your opinion, is this syndrome well treated by endovascular means? Do you think, because sometimes the right iliac artery compress actually the distal cava, not just the left iliac vein. And do you think on those cases the endovascular treatment should not be offered? What do you think about this? Because it was actually, there are a lot of reports of contralateral thrombosis. Or do you think it's related to the stent used? Wall stent, it's closed cells stent. Do you think that open cell systems would have a different long-term evolution? What do you think about that?
Well, you bring up an excellent problem to discuss, because it is a problem. And one of the reasons I think the appropriate use criteria that we just published in the Journal of Vascular Surgery, Venous and Lymphatic Disorders is so important, because it really tells everybody that be careful, don't do iliac vein stent to prevent deep vein thrombosis. Don't do it if the patient comes with ankle swelling and telangiectasia. And don't even do it for C2 disease, which is simple varicose veins, if you find it as an additional finding. And certainly don't do it in asymptomatic patients where you find it as a result of a more extensive evaluation, abdominal duplex scan or CT scan. So the first thing is, be sure that the patient has venous congestion because of the iliac vein obstruction, and the patient has symptoms and advanced chronic venous insufficiency, which is a class for B, C, class 5, class 6 venous ulcers. So I think if you have a symptomatic patient and if you have appropriate indication, I think it is a very good operation. But you bring up issues that some stents are not suitable for very proximal compression, or for compression that also includes, for instance, the distal inferior vena cava. So what are the options you have? Clearly, the wall stent is very soft at the end, so it doesn't have a high resistance. The technique that Raju described, where he added a Gianturco stent proximally, it had two purposes. Number one, it is stronger than the end of the wall stent, and it has very large interstices between the struts of the stent that you need to minimize the risk of contralateral obstruction. I am convinced if you place wall stents into the vena cava that touches the contralateral side, your patient, and these are frequently young women, you know, your patient sooner or later will have contralateral problems. So what do you have to do? If you don't use the Gianturco stent, if you have to go into the inferior vena cava, you have to do a kissing stent or what we have done, we practically enlarged the portion of the wall stent that covers the contralateral side. We just opened it up with a balloon. But I would say a kissing stent or a reconstruction that I showed you with a K-valve stent and bilateral iliac stents is needed. I think the ultimate solution will be a dedicated bifurcated ilio-K-valve stent.
Okay. And how long do you keep the arteriovenous fistula open in the PTFE graft, the iliocaval PTFE graft?
The fact is that PTFE graft, if you start from the groin with a PTFE graft, it needs an arteriovenous fistula. You don't have enough flow from the femoral vein to keep a PTFE graft open. You know, PTFE graft is thrombogenic. You need a certain amount of flow to minimize the thrombus deposition on the surface. So yes, you need it. I used to keep it about 3 months. Now I would say that if you have good flow, I will take it down in 4 to 6 weeks. In some patients, if you have poor inflow and the patient is doing all right, sometimes we kept it going in the long run, sometimes even for several months or a year. So in general, though, I would say 6 weeks is a good time.
Okay. Dr. Arno?
Well, Peter, thank you very much. I enjoyed tremendously your presentation. Congratulations.
Thank you.
And it's really amazing, and many subjects that you touched that really keep us awake, that we still have to have our regular open surgery skills alive and awake. We do share, you know, we know very well each other, and we do share, I think, most of the concepts, if not all. And I must say that we have done some palm operations a long time since I don't do it, but I remember here at least that I did a little less than a dozen of palmas. I did live in my mother when I did a venous thrombectomy in her when she was 70 and had a vena cava and iliac thrombosis, as you know, and many people thought I was crazy, but she survived for 27 years with that palmar functioning. And we do have some cancer patients that the iliac had to be removed, and we did palm operations in the immediate phase, not late, and they are working perfectly. One of my assistants who does echography told me today that she did an echo Doppler. I don't know, I think Bernardo or Alberto asked for it, Fatima Villaverde, and she has a palmar procedure that I did, I believe, 27 years ago, and she's still patent and fine. Another subject I would like to touch is regarding the temporary therapeutic arteriovenous fistula, how I'd call it TTAVF. We have the same concept. I must tell you that I tried many different concepts for this. And what we do now is the PTFE loop, which is easy to close, and it's really fantastic. Mayen-Turner syndrome, huh? It's a big trend now, and we do have, I believe, around 200 patients treated with that, right, Bernardo?
Yes.
If we do, yes. In the last years, I started it many years ago, and we have the same indications. We don't treat asymptomatic or oligosymptomatic patients because they do well. And once you implant a stent, you implant a disease in the patients that needs long-term treatment. So it has to have a good indication. What I would like to ask you is about, I know you don't have in the United States, but what's your opinion on the oblique stents, the ones that spare the entering of in the vena cava?
Yeah, I think I love the concept because it not only is an oblique stent, it's a German stent. Do you have it in Brazil?
Yes, we do.
So it is not only a perfect cut, but also the proximal portion of the stent is stronger, and the distal portion is more flexible. So I really like it. Unfortunately, we don't have it yet.
Okay. Bernardo, I think we should open for the questions of the audience.
Yes, there are a lot of questions. I will start reading here a question from Cleoni Pedron from the south of Brazil. A patient with 37 years old with class 6 disease, we've submitted to recanalization and implant of stent in the iliac vein, and has also insufficiency of the femoral popliteal segment and insufficiency of the superficial veins. Which treatment would you suggest, Dr. Gloviczki? You want me to repeat the question?
No, you don't have to repeat it. So the iliac vein was stented.
Yes.
Iliac vein was stented, and there is residual superficial and deep incompetence.
Yes.
Right? Yeah, I think if the iliac vein is stenting, there is no outflow obstruction, I would treat the superficial venous incompetence.
Okay.
You know, superficial and perforator vein incompetence, because obviously, for obvious reason, because, you know, deep vein incompetence is a challenging problem, and you know, we have tried all type of open procedures, and we don't have a reliable open, and we don't have an endovascular procedure.
Okay. There are some more questions. If you want to make a question, you can also, vocês podem também apertar o botão na parte inferior do vídeo, levantar a mão que a gente localiza aqui. There is a question, Dr. Gloviczki, from Pablo Bunch from Patagonia, Argentina.
I love Patagonia. We went there with Arno, right? Arno, we love Patagonia. Okay.
Well,
beautiful,
yeah.
beautiful.
Welcome, Pablo. Do you anticoagulate the patients in the surgeries for popliteal aneurysm, palmar graft, and other reconstructions with veins?
Yes, yeah. Well, obviously, intraoperatively always. And as soon as I can, you know, we start them with low dose, and as soon as we can, we fully anticoagulate them. So any venous reconstruction, we anticoagulate them for 3 months, unless they have underlying thrombophilia, or if they are post-thrombotic patients, or if they have a PTFE graft coming from the groin, we would keep them on lifelong anticoagulation.
Okay. And there is another question from Marco Manarino. What are your views on superior vena cava reconstruction for patients under dialysis?
Well, I was considering that those are high-risk patients. I would do everything possible to avoid a midline sternotomy, you know. So we certainly would try all endovascular recanalization techniques before reconstructions. On the other hand, if you have to do it, and maybe you have a situation where the innominate vein is open, the results have been very good because the patient already has an arteriovenous fistula. So the flow is pretty high. But considering that most of these patients are high-risk patients, that's why I would like to avoid, certainly would do a reconstruction with a fistula to the internal jugular vein, if that's an option. If the occlusion is only a subclavian vein occlusion.
Okay, excellent. And what are the sizes of the PTFE grafts in general you choose for the iliocaval reconstruction and the femoral iliac?
Yeah, very, very good question. What you have to think of that PTFE develops a 1 to 2 millimeter pseudo-intima. So I like to put in as large a PTFE graft as I can. Never put smaller than 10, 12 or 14 if I come from the groin. Because you have a 1 to 2 millimeter pseudo-intima, and that translates into 2 to 4 millimeter on each side. So I would say if you come from the femoral, I like to use a 12. If you come from the iliac, I use a 14. And then for vena cava, infrarenal vena cava, we use 20, 22s.
Okay. And concerning the palma surgery, which tips and tricks would you suggest for avoiding kinking on the donor side, and regarding the tunneling?
Very, very important. And again, that's why I'm saying that there is a learning curve, because you do a couple of times where you have to go back next day and it occludes and you know what you did wrong. Well, first, obviously, a very gentle atraumatic technique to dissect the vein. Usually, I used to actually use subcutaneous harvesting, but I prefer short incisions because I have a better visual control. So very gentle handling. Once your vein is removed, obviously it is connected at the groin still to the femoral vein. Then I dissect the common femoral vein and put a Satinsky clamp not on the saphenous vein, but on the mid-common femoral veins, and then inject the vein with a heparin saline and inflate, so I can see that there is no external band or anything on the vein, because you want to have a good inflow. And then when you turn it over, you obviously make a good tunnel, and I actually like to use my 2 fingers to make it big enough because you don't want any compression. Occasionally, you can see a kink once you turned it over. What I have done, rarely it was needed, but then if there is no way to avoid a kink, I just cut out a piece from the anterior common femoral vein and turn the whole thing 180 degrees and resuture the common femoral vein patch practically. So practically you can actually turn that vein around, and if that's the only way to avoid a kink. But if you have a kink, you have a problem. So you might as well just prevent it. So it is, if you and then once you put it in the tunnel, again, I place a clamp on the common femoral vein, a Satinsky type or a Derra curved clamp, and then inject the heparin saline under pressure so that I can see that it's completely distended. and then I do the anastomosis with the inflow femoral vein.
If I can add 2 comments on your thoughts. I usually don't dissect the branches that are at the groin of the venous femoral junction. I think that if you leave the branches, you have a better, like the roots of a tree to the saphenous vein on the side that is the donor, who is going to be the receptor of the flow. Mm-hmm. And second, I think it's important, I would like to have your opinion on that graft should not be stretched, the arterial graft. It has to be kept a little bit loose.
Absolutely. Yeah, no, I agree with that. Yeah.
I think it works better. I don't know. What do you think about it?
No, I fully agree. Fully agree. This is not going to be an arterial graft, and I like to distend it completely so that there is no compression in any areas or kink or bend, but then you give a nice gentle curve.
Bernardo, let me ask you another question, Peter. If you have the chance to keep a patient that has been treated by a large venous reconstruction, mostly by prosthetics, and there's no contraindication to long-term anticoagulation, would you keep that patient for life?
I think if it is for an iliofemoral obstruction, I would. Mm-hmm. Yeah. Not for a vena cava. We very seldom, if it's just a vena cava graft, or if it's a very short, we seldom do short iliocaval grafts anymore. But I would use common sense. You have very high flow in the vena cava. You don't need anticoagulation unless the patient has an underlying thrombophilia.
Excellent. It's really nice to understand and to think about those complex reconstructions. And it's very important, I think, there's a very important message because nowadays you have a lot of information regarding endovascular and less invasive treatments, but it's necessary to discuss and to understand the ways to treat the complications of the endovascular treatment, as Dr. Gloviczki has shown us. It's really amazing. Dr. Gloviczki, there is another question here from Wilson Michaelis. He asks you which diameter of the popliteal vein aneurysm there is an indication for surgery.
Excellent question. Excellent question. Well, obviously, it depends on a lot of things. It depends on the risk of the patient, the age of the patient, and particularly whether you have a symptomatic patient or not. You know, most of the popliteal vein aneurysm that have been reported or that I have seen too, those were patients who actually had already a pulmonary embolism, like the patient I showed. So they are searching and they find the source. To operate on an asymptomatic popliteal vein aneurysm, you have to have a good indication and the large aneurysm. And I would say that the aneurysm should be 3 centimeters or larger. You know, if it's symptomatic, it's easy. But certainly in an older patient with a aneurysmal popliteal vein, I would not push for reconstruction. Very frequently, these aneurysms develop at a valve junction or at at an area where the small saphenous vein joins the popliteal vein, and there you can have almost normally some enlargement. So I think B critical, symptomatic, yes, asymptomatic, depending on the age and size of the aneurysm. Younger patients, I would say maybe 2.5 centimeter. In adults, I would say I would even go to 3.
Okay.
Excellent. Well, it was really, Dr. Arno, any more questions?
No, I just want to congratulate. It was an outstanding presentation. I think I see here more than questions, people congratulating you for your presentation here in the small talk here, and many people from Italy, from Argentina, from many places who joined us tonight. You know, this is a very specialist subject, not for everybody. Yeah, we know that you also have to love it and like to have the skills. I think. Thank you very much, Peter. We hope we're going to have more chance to have you more time with us. Yeah, you have so much to share.
Would love to. Would love to go back to Patagonia.
Yeah. Yeah. But then I think we are going to stay in that ship in the lake, the ship hotel, I don't know.
Dr. Gloviczki, there is a late question here. Is there indication for renal autotransplantation in the treatment of nutcracker syndrome?
I would say occasionally, yes. There have been reports when, especially in patients who failed the transposition, where clearly the only good solution. So I used to object, but I don't anymore. I think reading a couple of nice series of autotransplantation, I would say that I can imagine scenarios when that actually helps. So selectively, very selectively.
Okay, excellent. I would like to thank everybody. Gostaria de agradecer a todos por terem participado desse Clube da Artéria. I would like to thank Dr. Gloviczki to share your expertise with us. It was a very nice evening. We really were happy for participating in this event. Thank you very much. I would like to thank all the colleagues that joined us during this period. And thank you very much and have a nice evening, everybody.
Thank you very much. Thank you for inviting me, and have a great rest of the evening.
Thank you.